Rheumatic fever. Definition: diffuse inflammatory disease typically caused by abnormal immune response to upper respiratory tract infection with group A beta hemolytic streptococci. Etiology: there are three theories. Delayed immune response to pharyngeal infection with rheumatogenic strains of group A beta hemolytic streptococci, then after a latent period of 1 to 3 weeks, antibody-induced immunological damage occurred to heart valves, joints, subcutaneous tissue, basal ganglia. The three theories are antigenic similarity, cross-reactivity theory, altered antigenicity, autoimmune theory, hypersensitivity theory. Antigenic similarity or cross-reactivity theory: the antigen of streptococci is similar to the antigens of heart and connective tissue, so antibodies produced against streptococci can react with cardiac muscle and other connective tissue. Altered antigenicity, autoimmune theory: streptococci or its toxins may change the character of the connective tissue, making it abnormal to the body, so they act as antigens and stimulate autoantibodies against it. Hypersensitivity theory: streptococcal antigens stimulate antibodies and complements, leading to complex-mediated injury. Pathology: site: rheumatic fever bites the heart and licks the joints. Joints: synovial membrane, heart, pancreatitis, CNS, skin and subcutaneous tissue, small blood vessels, serous membranes, pleura, peritoneum, and pericardial. Types: there are two types, exudative lesion and proliferative lesion. Exudative, affecting mainly the serous membrane, they heal mostly without scarring or deformity. Proliferative lesion, formation of atroph nodules, affecting mainly heart and skin, and heals by fibrosis. It consists of, from inside to outside, fibrinoid degeneration, lymphocytes, plasma cells, atroph giant cells, fibroblasts, and layers of fibrosis. Predisposing factors: recurrent streptococcal infections of pharynx and tonsils. Age: most common between 5 to 15 years, rare below 3 and above 30. Equal in both sex, but chorea is more common in females. Familial, due to similar environment, overcrowding, and genetic predisposition. Common in third world countries. Clinical picture: latent period 1 to 3 weeks. We have major criteria and minor criteria. Major criteria with mnemonic: cancer, C. carditis, A. arthritis, N. subcutaneous nodules, C. chorea, ER. erythema marginatum. Erythema marginatum, it occurs in the form of areas of erythema with central pallor, side, trunk, and proximal part of limbs, non-pruritic and non-painful. Chorea, Sydenham's chorea, 10% of the cases, involuntary sudden movements with emotional instability, more common in females, self-limiting, appears very late after streptococcal infection, 6 months, so it's not associated with arthritis, and ESR is not raised. Then we have subcutaneous nodule. They are very rare, small, painless, tenderless, firm nodule, and not adherent to the skin. Accumulation of atroph nodules is the etiology. It's over bony prominences and tendons, like dorsum of the hands and feet. Importance: it's associated with severe carditis. Arthritis: it's found in 75% of the patients. Polyarthritis, affecting big joints such as knees, elbows, and ankles. Asymmetrical, migratory. The affected joints show hotness, redness, tenderness, swelling with limitation of movement. Dramatic response to salicylates, and the duration is about 2 to 6 weeks. No deformity, leaving joints with complete resolution. In children, carditis more than arthritis. In adults, arthritis more than carditis. Then we have carditis. It's found in 50% of the patients. Rheumatic fever affects the 3 layers of the heart, causing pancarditis. Pericarditis: dry pericarditis, causing stitching, pain, pericardial rub. Pericardial effusion is very less common, while there's never constrictive pericarditis. Myocarditis: tachycardia not proportional to the degree of fever, tic-tac rhythm due to loss of muscular component of S1, heart failure, arrhythmia, and maybe heart block. Endocarditis or valvulitis: the order of frequency: mitral, then aortic, then tricuspid, then pulmonary. Carey-Combs murmur: transient mid-diastolic murmur of the mitral stenosis in acute stage due to swelling of the mitral cusps, causing narrowing of the mitral valve. Later on, over years, fibrosis leading to stenosis, regurg, or both. And then the minor criteria: with mnemonic peace, prolonged PR interval in the ECG more than 0.22 seconds due to myocarditis, elevated ESR, A. arthralgia, painful joints without swelling, CRP elevated, and elevated temperature or fever. I didn't make up this mnemonic. Other manifestations of rheumatic fever: pallor, pleurisy, pneumonia, peritonitis causing abdominal pain. Diagnosis of rheumatic fever: Duckett-Jones criteria, 2 major criteria or 1 major with 2 minor, with evidence of recent streptococcal infection, positive throat culture, increased anti-streptolysin O titr, and scarlet fever. There's no need to say that if arthritis is taken as major criteria, we don't consider arthralgia as minor criteria, and if carditis is taken as major criteria, we don't consider prolonged PR as minor criteria. Complications: acute complications, heart failure, arrhythmia, heart block. Chronic complications: they are the complications of valvular heart diseases. Differential diagnosis: fever of unknown origin, Henoch-Schönlein purpura, acute leukemia, SLE, juvenile rheumatoid arthritis, and bacterial arthritis. And finally, infective endocarditis. Investigations: there is no specific confirmatory test, and they are divided into lab and cardiac. Lab: evidence of streptococcal infection, leukocytosis, elevated ESR and CRP. Anti-streptolysin O titr is higher than 250 Todd units in adults and higher than 333 Todd units in children, because this indicates recent infection. Throat culture may reveal group A streptococci. The normal units of streptolysin titr is 150 Todd units. Cardiac: X-ray, cardiac enlargement, ECG, prolonged PR interval more than 0.22 seconds due to myocarditis with arrhythmia and heart block. Echo, cardiac enlargement and valve lesions. So cardiac shows evidence of carditis. Signs of rheumatic activity: major or minor criteria, with lab tests elevated ESR, CRP, and anti-streptolysin O titr with leukocytosis. Treatment is divided into prophylactic, curative, and treatment of complications. Treatment of complications: chorea, tranquilizers such as chlorpromazine and haloperidol is very effective in severe cases. Congestive heart failure, digitalis dilator diuretics, and unlike normal heart failure, rheumatic heart failure responds well to cortisone. Prophylactic, divided into primary, secondary, and tertiary prevention. Primary prevention: to prevent rheumatic fever by proper management of upper respiratory tract infection and tonsillectomy of chronically infected tonsils. Secondary prevention: to prevent recurrence of rheumatic activity by long-acting penicillin, benzazine, penicillin, 1.2 million units every 2 to 4 weeks, intramuscular, or penicillin V, 250 mg per 12 hours orally, or erythromycin 250 mg per 12 hours orally in case of allergy to penicillin for 5 years after the last attack till the age of 25 or forever. Tertiary prevention: to prevent infective endocarditis. Then we have the curative treatment. Number 1, complete bed rest till improvement of all signs and symptoms. Diet: light meals and salt restriction. Antibiotics, anti-inflammatory drugs. Antibiotics: benzyl penicillin G, 1 intramuscular injection, 600,000 to 1.2 million units for about 10 days, or penicillin V, 250 mg each 6 hours orally for about 10 days. Erythromycin, 250 mg each 6 hours orally for 10 days in case of allergy to penicillin. Anti-inflammatory drugs: corticosteroids for carditis, prednisone, 1 mg per kilo per day in 4 divided doses for 4 weeks, then gradual tapering within 4 weeks. Aspirin should be added during steroid withdrawal to avoid rebound activity. Aspirin for arthritis, 100 mg per kilo per day in 6 divided doses up to satisfactory laboratory findings. Gradual withdrawal is important to avoid rebound arthritis. Side effects of aspirin are with the mnemonic of aspirin: A. aplastic anemia. S. salt and water retention leading to edema and worsening of hypertension and heart failure. P. peptic ulcer. R. rash. I. induce bronchial asthma. I didn't make this up. N. nephrotoxicity, interstitial nephritis, and rarely acute renal failure. And this concludes the rheumatic fever. Infective endocarditis. Definition: infection of the endocardium. They are classified into 2 forms depending on the virulence of the organism: subacute infective endocarditis and acute infective endocarditis. Subacute, most common and requires combinations of 2 factors: infection and cardiac lesion. While the acute infective endocarditis, it affects healthy endocardium, normal valves, and usually occurs in the right side of the heart of addicts, caused by Staphylococcus aureus. Etiology: The development of infective endocarditis requires combination of two factors, infection and underlying cardiac disease. Infection, any organism, but commonly bacteria. Gram-positive cocci, such as Streptococcus viridans, which is the most common organism from tooth extraction, Streptococcus faecalis from GIT procedures, Staph aureus, cardiac catheterization, and Staph epidermidis accounts for 30% of cases of prosthetic valve endocarditis. Gram-negative bacilli, Haemophilus influenza, Klebsiella pseudomonas. Others, Rickettsia, chlamydia, fungi. Underlying cardiac disease. In fact, all situations inducing turbulent blood flow are favorable to infective endocarditis. Valvular diseases, left more than right, regurg more than stenosis, all valvular heart diseases except mitral stenosis due to marked fibrosis, prosthetic artificial valve endocarditis. Congenital heart diseases, especially small VSD, PDA, coarctation of aorta, pulmonary stenosis, uncommon in ASD because of the low pressure gradient between the two atria. And finally, myocardial infarction. Pathology. Vegetations are formed over the valvular and mural endocardium, causing valvular damage. The organism is in the center, surrounded by fibrin and platelets. Vegetations may detach, leading to embolization. Left-sided in 90% of the cases and rare on the right side. The vegetation is big, friable, and septic. The myocardium may contain foci of inflammation. Clinical picture. Manifestations of the disease are due to toxemia, embolization, and immune complexes. We have extracardiac manifestations and cardiac manifestations. Cardiac manifestations show features of the underlying cardiac disease which already existed before the infective endocarditis. Number 2, precipitation of heart failure due to toxic myocarditis and increased valvular damage. New murmurs due to perforated cusps or ruptured chordae tendineae. Then we have the extracardiac manifestations: face, upper lower limb, spleen, kidney, CNS, and lung, infection, pneumonia, infarction due to pulmonary embolism in the right-sided endocarditis, which is rare, CNS, infection, meningitis, encephalitis, mycotic aneurysm, infarction, embolic hemiplegia, subarachnoid hemorrhage, kidney, infection from immune complexes presenting as nephrotic syndrome up to chronic renal failure, infarction, loin pain and hematuria, spleen, infection, mild enlarged tender spleen in 80% of the cases, infarction, stitching, pain and splenic rub, upper and lower limbs, clubbing, splinter, hemorrhage, Osler's nodules, Janeway's nodule, abnormalities of the radial pulse. Abnormalities of the radial pulse, tachycardia due to fever, absent pulse due to embolization of brachial artery, Janeway's nodule, small painless patches on the palm, Osler's nodule, small painful, intracutaneous in the pulp of fingers and toes due to toxic endothelial hyperplasia of the capillary, splinter hemorrhage, longitudinal hemorrhage under the nails due to rupture of capillaries from toxemia, clubbing. It occurs with long-standing cases. And finally, face, fever, low-grade prolonged fever. Any prolonged, unexplained fever in cardiac patient, it should be considered and treated as infective endocarditis until proved otherwise. Pallor and toxic faces, eye, subconjunctival hemorrhage from toxemia, rust spots, areas of retinal hemorrhage with pale center, sudden blindness due to embolism of central retinal artery. Then we have investigations: blood culture, echocardiography, blood picture, urine analysis, and immune complexes. Immune complexes are presented in the circulation of most patients. Urine analysis for proteinuria and hematuria. Blood picture, anemia, leukocytosis, elevated ESR. Echocardiography for vegetations. Small vegetations can be detected by transesophageal echo, and it's an important investigation for the diagnosis and monitoring of the disease. Blood culture for the organism is the most important investigation. It's positive in most cases, 90%. At least 3 samples are taken during fever and cultured under aerobic and anaerobic conditions. The results are observed from 3 days up to 3 weeks. Negative culture can be seen in some organisms such as fungi, and antibiotic treatment started before taking the blood sample. Duke's criteria for the diagnosis of infective endocarditis. We have major and minor criteria. Major criteria: positive blood culture for infective endocarditis, typical microorganism consistent with infective endocarditis for 2 separate blood cultures, such as very dense streptococci, Streptococcus bovis, or community-acquired Staphylococcus aureus or enterococci in absence of primary focus. Echocardiogram finding such as abscess, new valve regurgitation, intracardiac mass on valve or supporting structure. The minor criteria are 6: fever more than 38, vascular, major criteria emboli, mycotic aneurysm, conjunctival hemorrhage, Janeway lesions, serological studies supporting infection, microbiological evidence, positive blood culture, but it doesn't meet major criterion, immunological, Ross spots, ossular nodules, glomerulonephritis, and rheumatoid factor, echocardiogram finding, which may be consistent with infective endocarditis, but it's not the classic presentation. Clinical criteria for infective endocarditis require 2 major or 1 major, 3 minor or 5 minor. We should compare between rheumatic fever and infective endocarditis. Fleeting arthritis and erythema marginatum are positive in rheumatic fever but negative in infective endocarditis, while petechiae, hematuria, clubbing, splenic enlargement, and embolization are positive in infective endocarditis and negative in rheumatic fever. Culture is negative in rheumatic fever and most probably positive in infective endocarditis. Treatment is divided into prophylactic and curative. Prophylactic: correction of the underlying cardiac lesion by closure of the VSD, for example, and prevention of infection by antibiotics. For tooth extraction and upper respiratory tract surgery, amoxicillin 2 gram orally 2 hours before and 6 hours after. For GIT and genitourinary procedures, ampicillin 2 gram IV plus gentamicin 80 mg IV 2 hours before and 6 hours after. For cardiac surgery and catheterization, cefotaxime 2 gram IV 2 hours before and 1 gram per 6 hours for 1 day after. Curative: general, bed rest with excess vitamins, hospital or CCU admission according to the clinical picture. Medical treatment: antibiotics. Once it's suspected, the patient should rest and receive large doses of antibiotics parenterally for at least 4 to 6 weeks. So we should start with penicillin G 24 million units per day IV plus gentamicin 80 mg per 8 hours intramuscular before the results of blood culture. Resistant cases should be treated according to the result of the blood culture. For strep viridans, penicillin G and gentamicin, like before, staphylococci, oxcloxdicloxacillin or vancomycin 1 gram per 12 hours IV, pseudomonas, ceftazidime 2 gram per 8 hours or carbapenem, fungal infections, amphotericin B, treatment of complications such as heart failure. Heparin and other anticoagulants are contraindicated in infective endocarditis for the fear of rupture of mycotic aneurysm in the brain. Surgical treatment: replacement of severely damaged valve or replacement of infective prostatic valve and removal of myocardial abscess. And this concludes infective endocarditis. Pericardial diseases: acute dry pericarditis, etiology, 10 causes, idiopathic, most probably viral, infection, viral Coxsackie B or echoviruses, the commonest cause, bacterial, TB, infarction, may occur as early or late complications, irradiation, infiltration from leukemia, lymphoma, breast cancer, iatrogenic hydralazine or prosanamide, immunological SLE, rheumatoid arthritis, rheumatic fever, renal failure, trauma, post-cardiotomy syndrome. Clinical picture: general symptoms, fahem, fever, anorexia, headache, malaise, local symptoms, pain, signs, pericardial rub, and features of the cause. The characteristics of pain: site, pericardial, character, stitching, radiation to the shoulders, duration, continuous, increased by movement and respiration, decreased by sitting and leaning forward, and associated with pleurisy. Pericardial rub characteristics: due to friction of 2 layers of the inflamed pericardium, superficial lasery sound, not related to the cardiac cycle, increased by pressing of the stethoscope against the chest wall, decreased by development of effusion. This sound doesn't disappear with holding the respiration, unlike the pleural rub. Differential diagnosis between acute myocardial infarction and acute pericarditis. Chest pain in myocardial infarction rarely affected by respiration of movement, but it worsens in pericarditis. Radiation in myocardial infarction is usually in the arms and the jaw, but it's rarely in pericarditis. Fever 2 to 3 days after onset of myocardial infarction, but at the onset of pericarditis. Pericardial rub is transient in myocardial infarction, but it's persistent in pericarditis. Investigations: elevated ST segment and inverted T wave. Differential diagnosis of elevated ST segment, acute pericarditis, myocardial infarction, and Prinz metal angina. Concave elevation in acute pericarditis, convex elevation in myocardial infarction, and flat in Prinz metal angina. In all leads in acute pericarditis, in some leads in myocardial infarction and Prinz metal angina. Pathological cue is absent in acute pericarditis and Prinz metal angina, but it's present in myocardial infarction. Cardiac enzymes are normal in acute pericarditis and Prinz metal angina, but it's elevated in myocardial infarction. Treatment of the cause in acute dry pericarditis, if you forgot, and analgesics with anti-inflammatory such as indomethacin. Then pericardial effusion. Etiology: according to the fluid in the pericardial sac. We have 4 types: exudate, transudate, hemipericardium, and chylous effusion. Chylous effusion: accumulation of lymph from obstruction or injury of the thoracic duct. Hemipericardium: accumulation of blood from rupture of aortic aneurysm or trauma. Transudate: hydropericardium, low cell and protein content less than 3 gram percentage and specific gravity less than 1018. The same causes of generalized edema. Heart failure increases hydrostatic pressure, or liver cirrhosis, nephrotic syndrome, malnutrition causing hypoproteinemia. And finally, exudate or seropericardium, increased cell and protein content more than 3 gram percentage and specific gravity more than 1018 due to increased capillary permeability, produced by all causes of dry pericarditis. TB is the most common cause. Hemorrhagic effusion: exudate with excessive RBCs such as malignancy, myocardial infarction, TB, and chronic renal failure. Hemodynamics: it depends on the amount and the rate of accumulation, and the rate is the most important factor, because if 200 milliliters with rapid rate of accumulation, it can lead to cardiac tamponade, while if 2 liters with very slow rate of accumulation, it will only lead to pericardial effusion because there is pericardial stretching. The effusion results in compression of the heart, so it interferes with cardiac relaxation and limits ventricular filling. It affects right side more than the left side due to high pressure in the left side, and this results in low cardiac output and systemic congestion. So the clinical picture: 2 hemodynamics and 2 Ps. 2 hemodynamics: symptoms of systemic congestion, symptoms of low cardiac output. The first P is pain, dull aching pain due to stretch of parietal pericardium. The other P is pressure manifestations. On the lung, dyspnea improved by sitting up and leaning forwards. On esophagus, dysphagia. On left recurrent laryngeal nerve, hoarseness of voice. Signs: 2 hemodynamics and 2 Ps. Number 1, signs of systemic congestion. Neck veins, congested neck vein. Cosmal sign: inspiratory filling of neck vein due to failure of the heart to accept the increased venous return during inspiration. Frederick's sign: rapid, deep Y wave. The Y wave is equal to atrial emptying. Number 2, enlarged tender liver and ascites before lower limb edema, ascites precox due to kinking of the hepatic vein and obstruction of lymphatics passing through the central tendon of diaphragm, causing accumulation of lymph in the peritoneum. Signs of low cardiac output: cold hand pallor, low systolic blood pressure and weak pulse. Prayer's position: pulsus paradoxicus. Exaggerated inspiratory fall in systolic blood pressure more than 10 mm mercury. Normally there is slight fall in systolic blood pressure, but it never exceeds 10 mm mercury. Pulsus paradoxicus is an exaggerated of the normal, but it's not a paradox, so it's wrong nomenclature. Explanation: normally during inspiration, increased venous return to the right side of the heart leads to increased cardiac output, but there is expansion of the lung which takes part of the cardiac output of the right ventricle, so the net result is normal or minimal decrease in the cardiac output. While in pericardial effusion, during inspiration, increased venous return, but there is compression of the right side of the heart, preventing it from proper filling of the ventricles, so no increase in the cardiac output. Expansion of the lung takes part of the cardiac output of the right ventricle, so the net result is massive decrease in cardiac output. Causes of pulsus paradoxicus are COPD, acute severe asthma, restrictive cardiomyopathy, constrictive pericarditis, and pericardial effusion. Cardiac examination, inspection and palpation, not visible and not palpable apex, pericardial bulge in children, percussion, dullness outside apex, dullness to the right border of the sternum, dullness over the second space which disappears on sitting, dullness below left scapula due to compression of left lung, Ewert's or Evert's sign, wide bare area, and auscultation. We have weak distant heart sounds. Complications, cardiac tamponade and constrictive pericarditis. Investigations, X-ray, flask-shaped heart, narrow base with sharp border, ECG, low voltage, echo. The most important criteria for diagnosis and for detection of severity. Catheterization not needed anymore after the echo. Aspiration or pericardiocentesis may be needed for diagnosis of the cause by analysis of the pericardial fluid. Differential diagnosis of pericardial effusion, right-sided heart failure, constrictive pericarditis, restrictive cardiomyopathy, tricuspid stenosis and tricuspid regurg, generalized edema, liver cirrhosis, nephrotic syndrome. Treatment of the cause, such as TB, pericardial aspiration or pericardiocentesis for cardiac tamponade, drainage of pus and injection of antibiotics and cytotoxic drugs, site of aspiration, the angle between the void process and left costal margin, surgical treatment, pericardiectomy and pericardio-pleural window, cardiac tamponade, the severest form of pericardial effusion, the same causes as pericardial effusion, but most common causes are idiopathic, chronic renal failure and cancer. Clinical picture the same as pericardial effusion, but we add Beck's triad, decreased systolic pressure, distended jugular vein, and diminished heart sounds. So remember Beck's triad, 3Ds. Investigations and treatment the same as pericardial effusion, but focus on pericardial aspiration. Constrictive pericarditis, fibrosis and marked adhesion between two layers of the pericardium. Etiology, same as dry pericarditis with the exception of rheumatic fever. The most common cause is TB and irradiation. Hemodynamics, same as pericardial effusion, but with some exceptions. Calcification of pericardium is common. Please concentrate on the calcification. Ventricular filling is reduced in late diastole when the elastic limit of the pericardium is reached. Clinical picture, symptoms similar to pericardial effusion, but with or without minimal pressure manifestations and atrial fibrillation in 30% of the cases. Signs similar to pericardial effusion, but with no special deciopatus, no Prayer's position. Cardiac signs, weak or absent apical pulsation with pericardial knock, high-pitched early diastolic sound due to sudden halting of the relaxing ventricles by rigid pericardium. Investigations, calcifications in X-ray, ECG, low voltage, flat or inverted T wave, echo, pericardial thickening, calcification to exclude effusion. CT and MRI are highly diagnostic. Treatment, pericardiectomy, treatment of the cause, TB, and complications such as AF, atrial fibrillation. Adhesive pericarditis, adhesions between pericardium and surrounding mediastinal structures and chest wall. It occurs as late complication of rheumatic fever or maybe due to extension of inflammation from neighboring structures, and this concludes the pericarditis.